I know I've seen a number of hands, and I know other people do have questions, so we can come to you in a minute. I want to now, we have some time with WHO and with IDF, and I want to make sure we, as the Global Patients Movement, make the most of that time. We're very privileged to have that. So I'd like to ask the audience, in thinking about the questions that you have, if we can refocus on the title of this session, which is Engaging Patients to Achieve Universal Health Coverage. With, these people in the room, with all the knowledge that they have, I'd like you to think about what we need to know from them in order to be actively and meaningfully engaged this year. Now, you have shared a number of ways that we can do that, but I'm sure people might be thinking, either globally, what more can we do, or on a national level. And so that's the kinds of questions it would be really useful to focus on. So I did already promise Orijit and Jean-Luc a question. So if we could take those two and take them to the panel and hopefully frame them in that way. I think we've lost all the microphones.
Jean Kaiserle from the FDI, World Dental Federation. We share the same letters FDI as IDF in a different order. I guess that reflects the link that many diabetes patients are suffering from gum disease. My question is more about it's a bit provocative because I'm representing healthcare providers. It's about the concept of universal health coverage. Of course, it refers to access to care, access to treatment. You made the point that by 2035 there might be 1 billion people suffering from diabetes. But universal health coverage also refers to access to prevention and access to promotion. And in addition to making sure that patients have access to care, we also have to make sure that people don't get sick. So I would be very interested to know from WHO and from a very strong patient association like IDF, what could be your role in terms of prevention and promotion for health? Thank you.
Thanks a lot. Let me start. Indeed, the concept of universal health coverage for WHO is not only about care. It is about personal services like treatment for diabetes or diagnostic, but it is also about population-wide services, and this is about health promotion and making sure that that the governments invest in helping their people not to have diabetes and not to have the risk of having diabetes. Of course, lifestyle, as it's sort of nicely called, lifestyle diseases are not always called by lifestyle, so we should not forget this. But nevertheless, I see that there are ample reasons why there is not more focus on that. But I don't think that these reasons are acceptable, because when we are talking about, if you compare now the situation with tobacco and with food, so of course the Tobacco Convention, which took some time to negotiate, was taking on board health promotion and prevention of a disease against which there was no treatment or very bad treatment or not very efficacious. Of course, if you have lung cancer, what can you really do? The treatment is difficult whatsoever. So therefore, this enabled really going against the tobacco industry to say, no, this is it. We must do something for our people. Now, in diseases like diabetes, and the access to medicine is not well done enough, and not everybody has it, and there are progress to be made to have universal aspects to treatment. But because there is a treatment and prevention and whatsoever, this diverts a little bit the discussion on what can be done in order to avoid that people go into this condition, and therefore the drive really to oblige to reduction of the consumption of sugar, for example, is only sort of medium tepid. And we hear about, and what about, this is employment, and all the sugar industry and food industry is employing so many people. If we do something about it, all these people will be in the street. So I would like to hear myself from a big patient association how you see that, and how you think there could be a stronger drive to cut the causes of a disease.
Yep. Yeah, thanks. It's a very good question indeed, and prevention is absolutely key, because whereas with type 1 diabetes, it's an autoimmune disorder, and you can't prevent that, at least not yet. Type 2 diabetes is potentially avoidable. It requires early detection, and then it requires the lifestyle changes in terms of diet and exercise. And we need to be blunt about it. I mean, the food industry is actually multifactorial. The food industry has an important part to play in reformulation, in eliminating some of the things that are bad in food. Britain has done well, I have to say, in relation to salt reduction. It's probably leading the world in terms of salt reduction, and that's good. And where a country is doing well, it should be praised by WHO on that. As far as tobacco is concerned, I agree with Marie-Paule totally. It's a risk factor for so many diseases, and I would be happy to see it outlawed, banned, overtaxed, or whatever. I don't smoke myself, so I declare a bit of an interest there. We believe, in our national associations, believe absolutely in the prevention agenda of change of lifestyle, of people taking far more exercise. And actually, that's when you look at the agencies that can come together to achieve that. It's local government, it's national government, it's the encouragement of sport, it's education, educating our young people, making sure that they adopt and retain physical exercise as part of their life. It's all changed in my lifetime. I've watched it. When I was young, you kicked a ball, you were constantly active. Nowadays, for a kid, it's sitting in front of a PlayStation with a bucket of sweet popcorn and a gallon of carbonated drink. No exercise and unsuitable food. Goodness me, I'm afraid it leads inexorably to the development of diseases like diabetes. But actually, we've got to go further than that. It's not just a question of using the education system to change habits. It's also, I think, a question of employers taking the health of their employees more seriously, of encouraging well health at work, because a healthier workforce is a more productive workforce and is a better society. So I think there's a lot of changes that have to be taken, which might loosely be grouped under what we would call the prevention umbrella.
It's a good point that's been made multiple times, actually, that we're focusing on the healthcare system, but the roles of other sectors and actors is also very important, and employers being one. I'm going to take maybe 3 questions next. So I think there was Origit, Rebecca, and is there one more? I can see a hand quite near the back. I can't see who it is. Is it Lars? No? Yes, okay. So first of all, Origit, Rebecca, and then Lars, and then we'll take them to the panel. I could ask you to keep the comments short, or the questions short.
Keep the answer short too.
And if I could ask you to keep the answers short.
Yes. I agree. All those you have already told us, and in just compare with Thailand case that nowadays the diabetes disease is already covered in the universal health coverage, but it's happened that it's have the separate fund for that. It's not so it's easy to manage under this diabetes fund. So what I think that it should be some kind of disease management approach and holistic care approach. That means I don't know whether from what you have told is you can separate into 2 fold, right? 1 fold is the hospital care, because you need when you have to refer, and 1 fold is the community care. and then they have actor in these several in these twofold as well, and maybe we have to focus in the community care. And in this case, for the community care, I think we have to promote more in the patient organization in order to involve, and it work because in the community, since we have community prevention fund, then they can support more and more the diabetes patient group. And the diabetes patient group right now is because diabetes is the disease, no matter you are the executive of the local government or you are the leader of the group. So it's happened that we can find out the champion of the group as well. And it's work that if the executive of the local government, he also has diabetes disease, he can be a presenter or promoter of how to avoid or how to have a better care of this diabetes disease. And people believe so much because he is the executive of the that area. So what I suggest is maybe we can promote more and more in the champion of diabetes patient group in the community level. And this one is smart enough to work with the healthcare officer in order, in some case, that they can collaborate and then can refer the patient easily to have a medical care in the hospital.
That's great points, thank you. Rebecca, I think you're next.
Thank you. Rebecca Shear from the Livestrong Foundation. I know you know some of our colleagues, especially over at the IDF. I was curious if both or either of you could speak to as the evolving plans are happening towards the Sustainable Development Goals and then the post-2015 MDG to SDG agenda, sort of what are your organizations or institutions doing to continue to keep patient or person-centered care at the center of those plans as they evolve? What's sort of the hot stuff happening there? And then secondly, what do you think are the opportunities for all of the patient organizations in the room so that we can play into and support and integrate our efforts into what you are doing as the post-2015 agenda evolves?
Thank you, Rebecca. And one more question before we invite the panel to comment.
Sir Hirst, I must say I was very impressed by your contribution. My name is Lars Etarp. I'm president of the International Federation of Psoriasis Association. I can tell you that the WHO board last year took a resolution on psoriasis as a severe inflammatory chronic NCD, and it will come up for decision in the General Assembly of WHO this year. I hope, I will ask you, can we count on you in that process and in the process thereafter when we will have a stronger voice in the NCD Alliance? Thank you.
Some interesting questions. Would you like to start?
Okay, post-2015, so WHO advocates for UHC being a goal for post-2015. It's not, it's not because we shy away from specific diseases. It is because if we want to be able to do something to really to promote health and not only to diminish the number of death and mortality, we need to take an approach that uncovers completely the complete spectrum between going from health promotion to prevention, treatment, rehabilitation, and palliative care. And so there is a lot of debate right now, and especially, I must say, by not that much by disease specific, but by population specific groups. and especially the world of women and child health is very, very vocal to say, let's continue with the MDGs as they are and forget about all the rest. So we really think that, yes, certainly some of the targets need to encompass MDG targets. Some of the targets need to be those of the HIV, TB, malaria world. Some of the targets must be the specific NCD targets, but the overall chapeau should be on everybody having access to the services that they need of appropriate quality and without encountering financial ruin or going down into poverty. Thanks.
Rebecca, we are in IDF and in the NCD Alliance taking 2015 very seriously. This is the opportunity that the world has to get the development framework for post-millennium development goals. And actually, when you look and see that 4/5 of the new cases of diabetes will be in low and middle income countries, and the majority of the people affected by it will be people of working age, diabetes is not just a health issue, it's a development issue. Therefore, it and health in a broader sense has to be at the heart of the post-2015 development framework. And we will be pushing very strongly for that. Yes, of course, Marie-Paule is quite right. Gestational diabetes and maternal health is extremely important, and we would want to see that picked up. But essentially, we've got to get health at the center of development goals, because development funds then follow it. And of course, that's looking at it on a global level, but at a national level. What it also means is that governments have got to pick up these targets as well. And for many governments, it means some difficult choices of cutting back budgets on other things to spend more money on health. I don't, however, believe that health is a cost. I believe health is an investment. And a prudent government will invest in the health of its people, because a healthier population is a population that will aid development, and I think be a happier and healthier community. I just want to finish by saying one point about why this is all important and why support for people with conditions is vital. Someone with diabetes on average will see their doctor or their specialist for 4 hours in the course of the year. For the other 8,756 hours, they are managing their condition themselves. And it's not a simple matter of popping a pill once a day. It's a question of living with a chronic condition that requires vigilance in order to maintain best health outcomes.
Just to say, of course, something I should have mentioned also. We, WHO, we are certainly very happy to support the representative of specific diseases to push forward discussion or resolution at the World Health Assembly or Executive Board, because this is really. A resolution doesn't change the world, of course, but it puts the focus on specific issues, and certainly my colleagues who are responsible more specifically of these diseases will be happy to help on that.
Okay, I know there are more questions, but we are sort of running out of time in this section of the session. So I would like to ask, I think it may be a slight reframing of actually what Rebecca said, but given we all have limited capacity, given we all are striving towards similar goals, I'd like to ask both the panelists what you would advise to us as to be where we should focus our efforts over the coming year in terms of being able to contribute and promote a patient-centred approach to universal health coverage. How can we help you as WHO and in countries, and how can we work with you to ensure we really have a patient-centred focus going forwards? If I could ask you both that question to finish off.
Joe, it's a good question. I think the biggest matter on the agenda in the next year will be agreement on the post-2015 development framework. That will be particularly important for low and middle income countries where from the perspective of my organization, the shadow of diabetes will fall most heavily. I think your member associations, I think, can individually and collectively through IAPO lobby for universal health coverage. It's absolutely vital because, make no mistake, it's seldom that somebody has just one chronic disease. There are often comorbidities and points of similarity. And I think it's very important, your organization does something that's very important. It also represents conditions which are not so mainstream and which could be in danger of being forgotten about or left behind. So there's a vital role, I think, in doing that to make sure that policymakers are aware that it's not just the big four or the big five or whatever, but also the other disease areas. Someone with a chronic condition, it's the same, they face the same problems in terms of the challenges in daily life, and we understand and feel for them.
There are lots of things that a patient association can do, of course. One of them, I would say, is to request from government, to request that they invest in health and to maintain through a parliamentarian, through lobbying, that it is not okay to just, to say that health is too expensive. The government must invest in the health of their people. So this is one, request from the government through parliamentarian, through advocates. The other one I would say is also to unite. Because when you come, and it was great to hear about diabetes, and it was great to see also that you put this also in a broader fight, which is for NCDs. But because when we request health and attention to health, is not my disease against your disease. It's not, it's not the chronic disease of children as compared to the aging population. It is about investment in health for all population, for all diseases. Then the third one is about prevention, insisting on prevention and promotion as well as on care. Of course, we have patients now. These need treatment now, and this must be paid attention to. But we must also be sure that, at the same time, there is investment into health promotion, and health promotion is much less expensive for the government than treatment. And so it must be on the forefront. How can we tolerate all the advertisement on TV for unhealthy food that we show a nice grandmother feeding this poisonous sugar thing to a grandchild? That is scandalous, You don't see anymore somebody smoking and advertising from Philip Morris. I haven't seen one for ages. But we see plenty of advertisement for cookies for children. This is something also that you could potentially advocate for. And then finally is also to advocate for your rights in terms of person, in terms of patients. We see also there's a lot of healthcare workers are our allies. Clearly they are, and we work with them. But also we must recognize also that healthcare professionals have also their own silos, their own union, and they see the healthcare one way. So engaging with them through the debate that we'll have also at WHO or elsewhere to see what is it that the patients and the people want to have as care. It's not only what the health care professional wants to give them. Thank you very much.
Well, I'd really like to thank you both because, we're coming into the closing session. We've all heard a lot over the past few days, but you've helped us to clarify, and I think this will inform the strategies and the initiatives that we can focus on and that will have an impact going forwards. So thank you very much. We're just coming into the final section, and I'd like to invite you to stay with us and stay up here for that as we just look at some reflections and highlights from the Congress. As I don't have the doofer, I might... So this is the closing session. I can't quite believe that we're all going home. We thought it would be nice just to show you a little bit about the Congress that we've had. So Twitter has gone mad. We launched IAPO tweets at the 2012 Congress. And I must say, based on that experience, we really didn't expect the literally hundreds of tweets and retweets that we've had. So here's a little selection of those. But do get on to IAPO tweets and hashtag GPC 2014 and continue the conversation. I think these really exemplify some of the core principles and expressions of partnership that we've expressed over the last few days. I'll go back. One of the other things that you've seen is Me Too, and if our colleagues at the back can put up a couple of those, I would encourage you still to download the app and to continue the discussion. Rebecca's gone very red now in the front here.
It's a really unique mission. You draw together a group of stakeholders that ordinarily I wouldn't have access to. So, for example, I work in the cancer community, and it's pretty much the same group of stakeholders that collaborate and come to conferences and workshops and events. But by being a member of IAPO, we're able to bridge disease groups and really get a broader perspective on a lot of the work that we're doing. So I really think it's the reach and the diversity of your members that's pretty unique, and that really is a big draw for us at the Livestrong Foundation.
And I think we have another example from Obatunde on what he's going to do next.
As an activist on access to healthcare, I have also strengthened my belief that advocacy by patient organizations should be evidence-based and research-based. So I'm going to have more focus, place more emphasis on evidence-based advocacy. I have also understood the importance of networking with other organizations and seeing the need for us, those of us that are working on HIV and other public health issues, to go beyond working on communicable diseases to also work on non-communicable diseases as well. Because people living with HIV and other people that have other health conditions, communicable diseases, also experience non-communicable diseases. So a person living with HIV could die from cancer, from diabetes, from kidney failure, and other non-communicable diseases. So we need to focus on that too.
I think Me Too is a really great tool for us. It's cost effective. Everybody can access it wherever you are in the world. So you can download it on your phone. You can do it from your computer, your iPad, your laptop when you get home. There's lots of questions up there around access to health. And if we can collect them in, we're going to develop a video wall like the one you just saw, and also a film that we can all use in our advocacy to exemplify the perspectives and the situations. So just wanted to share some of the key messages, and this is by no means comprehensive. It will take a little while for us to look at all the notes that we've taken over the past 3 days and to distill them into some cohesive and logical framework. But there were some that really kept coming through. The first was that universal health coverage isn't a nice thing to have. It's essential for development. And then patients must be involved in every aspect of the policy development and implementation of UHC, and from the beginning, not just as a tag-on at the end or a tick box exercise. And we have to work together. We have been really privileged and honoured to have such fantastic engagement from really key partners and stakeholders that we work with. The WHO, of course, also members of the World Health Professions Alliance, and also the pharmaceutical and healthcare industry, and the academics who are helping us to bring together that much needed data that we really need to complement and support our case. Some of the key messages and principal areas that we came out with on Saturday are here. I think there'll be a lot of wordsmithing. There's a lot of work still to do, but they came out very clearly. We need patient-centered, and we need to change the healthcare system. It needs reorienting. We need equity, quality, accountability, and standards. We need measurement. We want monitoring. Empowerment, communication, and education. engagement and collaboration in all aspects. And again, I think this was one of the key messages. We need to focus on value, not on cost. We need to look at it as investment, not as a cost burden. So, what are the next steps for us? This is a little timeline of what we've done so far and what we're looking at for the rest of this year. Before the Congress, for the first time, we shared some information with you to give you background information on what universal health coverage was and some country examples. Those resources are still available through our website, through Health Unlocked, and you can access them. We also had a webinar with members to talk about that. And here, of course, the value is that we have so much expertise within the room, and we've been able to share really tangible examples of what's going on in different countries. We've looked at lots of challenges, but thankfully we've seen that in some areas at least, there are some examples that are really working. And we have got, I think, the data we need now as IAPO to develop our own principles on universal health coverage from a patient perspective. And those then, in the next steps, April will be a very busy month as we develop them and wordsmith them. And then in May, we will have an IAPO policy statement that we can launch at the World Health Assembly. And then the rest of the year, we had some ideas of the forums that we could use this in, but we've had, some more focus and clarification on where we can really have an impact. So we'll be updating that. And of course, working with you to see what tools we can provide and how we can present this information so that you can use it or adapt it and use it yourselves. I'd just like to thank the many organisations that have supported the Congress, without whom we wouldn't be here, including the health programme of the European Union, and there's our premium sponsors here, Janssen, Lilly and Pharma, but also Amgen and Medtronic, and I haven't got them written down, so who have I missed? And Novartis, sorry, David. And Novartis, thank you all for making this possible. And of course, the other partners that we mentioned of the International Council of Nurses, the International Hospital Federation, the International Pharmaceutical Federation, the World Confederation for Physical Therapy, the World Dental Federation, and the World Medical Association, and also very much the WHO, with whom we have the official partnership, official relations. This is nearly the end, but we're a little bit early, so we have a bit of time. I don't know if anybody has any reflections on the Congress that they would like to share with us, or any suggestions for next time. I have to remind you about the evaluation cards as well, because please do fill them in. We do read them, and we do change and improve things and develop things for the next Congress. So please make sure that you do share your thoughts. And weren't we lucky with the weather? Does anybody have anything they would like to share? Is everybody ready for lunch? That's how it is. Great, okay. In that case, it's my pleasure now to hand over to IAPO's chair, KP Tsang, to formally say some words to close the Congress.
Good afternoon, everyone. Time runs more quickly than we wish. It's a time about to close our Congress. As Margaret Chan said, universal health coverage is the single most powerful concept that the public health service has to offer. I believe you will agree that this concept is not a simple concept. In particular, if we want to translate the concept into reality and the health outcome to the people, it is a long journey, as Marie-Paule said this morning. I believe all of us will get on this journey to the ultimate destination that we wish. May I once again extend our heartfelt thankfulness to the advisory committee of this Congress. The members are coming from our member organizations and our stakeholders. And also, thanks to the sponsors and the genuine support from the industry partners and the professional stakeholders. They offer very great support and sponsor to make this Congress possible. As well, may I thank all the board colleagues, the board members of IAPO, and the incredible IAPO staff team. They make this Congress as wonderful as they can. I believe all of you will agree, so let's give a pour to thank our staff team. And I also thank to all volunteers for this Congress, and I want to thank everyone in this room. I think you have taken something more or less from this Congress in the past few days. And as well, you have contributed to IAPO for drafting our policy statement on universal health coverage, which might be launched in the WHA in 2 months later. So your contribution is great to IAPO in this Congress. I hope all of you will have a good trip back home, and I look forward to see you in the coming IAPO activities. Thank you very much.
Thank you very much, KP. And lunch will be, as usual, in the Hyperion restaurant, which is just upstairs. So please enjoy it, and farewell.
We're absolutely on the same